We'll go ahead and get started in the interest of time. Um, Thank you, everybody, for coming to our webinar on patient safety rights. This is really about the role of charters and patient rights and patient safety around the world. We'll be showcasing the recent WHO Patient Safety Rights Charter, but we're also looking at other patient rights charters in different settings and declarations around the world on patient rights and exploring the role of patient rights in general, their roots in human rights, and in the ethics of the practice of medicine. Next slide, please. Next slide, please. So this is me. I am Helen Haskell. I am the chair of the Patient Safety and Quality Council at WPA. Next slide, please. And I will be your moderator today. If you need to use other languages, we have more than 50 languages available. Just click on the link in the chat, select your language, enter your name, and click attend. You can also click on unmute to listen, or you can read the transcription. Next slide, please. So the World Patients Alliance, just to tell you a little bit about who we are, it's a nonprofit umbrella organization of patients, patient organizations, and stakeholders from around the world. We provide a platform to empower and raise the patient's voice for safe, quality, and affordable health care. WPA works to ensure that patients have an active role in all the stages of healthcare, including planning, provision, monitoring, research, and evaluation of health services. There are no fees for patient advocacy organizations to become members, and our programs and initiatives are all at no cost to our patient advocacy organization members. Next slide, please. 9 principles of the World Patients Alliance are access to health care, patient-centered care, mitigating financial hardship, empowering patients, ensuring patient safety and quality, patient education and information, partnering and collaborating with both providers and patient organizations that are interested in improving and providing safe health care, patient engagement, and non-discrimination. Next slide, please. As you can see, we have quite a broad reach. WPA is the world's largest patient organization across all disease areas with 640 members, pretty much evenly spread across all world, all the different regions of the continents. Next slide, please. And with that, we will get into our agenda. So we have a really broad diversity of speakers today. We're going to start with a recording from Dr. Ashok Philip, the president of the World Medical Association, giving the physician's perspective and some of the history of human rights declarations by the World Medical Association. Dr. Ida Taha will introduce the WHO Patient Safety Rights Charter and some of the thoughts that have gone into its creation. Jolanta Balinska will talk about rights in Poland, and Cecilia will talk about rights in Uganda and other low and middle income countries. We will then have a discussion with questions and answers, and our chair of the board, Andrew Spiegel, will close us out. Next slide, please. So our first speaker is Dr. Ashok Philip. He's president of the World Medical Association. As I said, he's going to talk to us about some of the history and significance of declarations on patients' rights and ethics in medicine, which is something the World Medical Association has been doing since World War II. Unfortunately, Dr. Philip couldn't be here with us in person today, but he's recorded a presentation for us, and we're hoping that if his schedule permits, he might be able to join us later on for the discussion. So please, if you could run the recording, Harris.
Good day, everyone. Thank you for asking me to speak at this webinar. I'm grateful to Helen Haskell and her team. The relationship between the WPA and the WMA is new but evolving fast, and we look forward to further cooperation for the benefit of patients. So before we get to the topic proper, which is patient rights, allow me to digress a little. It's important to know how and when the WMA came into existence in order to understand its focus. Now, before World War II, there was an Association Professionnelle Internationale des Médecins, APIM, founded in 1925. It suspended its operations with the onset of World War II. Now, after the World War in 1947, after more than a year of preparatory work, the WMA was formed. APIM was dissolved and its residual assets were transferred to the WMA. At the time of its founding, there were 29 founder associations, and we now have 115 national medical associations as constituent members. The WMA focuses much of its efforts and activities on the ethics of medical practice. I believe that the circumstances surrounding our formation contributed greatly to this. The doctor's trial had just concluded in Nuremberg, and that had revealed horrendous acts by physicians against prisoners of the Nazi state. And details about the Japanese Unit 731 in Mongolia were also beginning to circulate. And this showed that the ethics of medical practice could not just be taken for granted, nor could we all assume that doctors would always act in the best interests of their patients. The ethical principles underlying medical practice need to be debated and made explicit.
जी अल्लाह का बड़ा शुक्र है अल्लाह की मेहरबानी है आप सुनो हेलो
The WMA's foundational or bedrock documents are the Declaration of Geneva from 1948, which many faculties use as a replacement for the Hippocratic Oath, the self-explanatory International Code of Medical Ethics from 1949, and the Declaration of Helsinki from 1964, which lays out guidelines for research involving human participants. The Declaration of Helsinki is widely referred to by researchers, and some of its provisions have been referred to or incorporated into laws in various jurisdictions. Now, of particular relevance to patients' rights is the Declaration of Lisbon. All these documents are revised regularly because although the ethical principles are eternal, the environment in which they operate changes, and we need to acknowledge and adjust to these changes. The Declaration of Helsinki was just reviewed and adopted in October this year in the city of its birth on its 60th anniversary. Now, all the documents that I mentioned emphasize patient autonomy. Basically, patients cannot be forced to accept a treatment. However, in some cases, doctors or health authorities may take a guardian to court if they feel that he is acting against the best interests of the patient. But any competent patient is free to act against medical advice, with the caveat that public health regulations may override individual choice, as for instance during epidemics or pandemics. Now, the principles underlying our approach are human dignity, autonomy, non-discrimination, and access to quality healthcare. Now, physicians must act according to their conscience, but always in the best interest of the patient. It is not permissible to push the patient to act according to the doctor's conscience. We must ensure that patient autonomy and justice are upheld. The claims of conscience and patient rights can be very complex and confusing, and it is in order to clarify these ideas that the Declaration of Lisbon was drafted. It lays out the principal rights of patients. Physicians and others involved in the provision of healthcare have a duty to recognize and uphold these rights, and we are also asked to oppose any attempts, whether by a government or any other body or institution, to curtail or abrogate them. Now, several rights are listed in the Declaration of Lisbon, such as the right to health, medical care of good quality, freedom of choice, self-determination, information, confidentiality, dignity, and religious assistance. I would like to look more deeply at the first three, but however, all the documents I've mentioned are available at the WMA's website for all to view. So what do we mean by good medical care? Basically, it should be appropriate for the level of care, whether primary, secondary, tertiary, and for the patient and for the disease. It is important that a physician should be involved in good medical care, at least beyond a certain level of seriousness or complexity. That physician should be free to make clinical and ethical decisions without undue interference from administrators, insurance, and the like. Now, the treatment shall be in accordance with accepted medical principles. The patient's rights do not extend to demanding that treatments not medically validated be used. Treatment should be in the best interest of the patient, and it certainly should not be about using the shiny new machine or the most expensive new drug. Now, the patient should be free to choose which doctor and which clinic or hospital should treat him. Of course, when the payer or provider is not the patient, this right may have to be restricted. For instance, you might have to see one of a few GPs depending on where you live and work, or depending on which is in your insurance network. And similarly, specialist care is dependent on referrals from primary care providers generally. But within these constraints, patients should have as free a choice as possible. A second opinion should not be denied. I believe this is one of those rights which is rarely exercised by patients, at least not to the extent that they should exercise it. Participation in research must be preceded by informed consent, which means explaining the purpose and potential risks and benefits of any tests or treatment. And in patients unable to give consent, a legally authorized representative must do so on his behalf. When patients take part in teaching and training, consent is required. It may sometimes be implicit in that university hospitals will use patients to teach students. And similarly, specialists may teach junior doctors at the bedside with just a perfunctory introduction rather than explicit consent. But in any case, if the patient refuses to allow this to continue, that refusal must be respected. Now, it's generally accepted that a patient should be given all the information about his health status that he needs or wants to know. And it is important that it is communicated clearly and comprehensibly. A patient can choose someone else to receive the information on his behalf, and where the patient is unconscious or incompetent, his guardian will receive the necessary information. Now, patients have a right of access to their medical records, something that all doctors should remember when writing their notes. All data about the patient should be stored securely and confidentially in a manner appropriate to the storage method, whether paper or electronic. Now, information can only be released with the patient's explicit consent or with a court order. Even after a patient's death, the requirements of confidentiality are not removed. Different jurisdictions require the records to be kept for different durations. Now, data that has been de-identified is not subject to these constraints, but it appears that big data and AI may combine to re-identify this de-identified data, at least in some cases. and we're still working out how to handle this. Now, as I mentioned earlier, our history, the WMA's history, makes patient rights and autonomy extremely important to us. We may be an association of doctors working to promote the interests of the profession, but this is done with the ultimate goal of ensuring, protecting, and promoting the benefits and interests of patients. We cannot work in a vacuum. Our partnerships with diverse organizations help us to craft policies of great breadth and depth. We look forward to expanding our relationship with the WPA to benefit patients everywhere. Thank you.
Thank you, Dr. Phillip, for that insightful and informative presentation. Hang on one second. I think that sort of sets the stage for our next presentation, which is from Dr. Ida Taha at the WHO, talking about the very newest patient rights charter, and probably the most comprehensive one, the Patient Safety Charter from the WHO. Dr. Taha is a technical officer at Patient Safety Flagship. She's a medical doctor, public health specialist, and has many, many duties at the Patient Safety Flagship, and really led the development of the Patient Safety Rights Charter. We're so pleased to have you, Ida. Next slide, please. And Ida, you can start your presentation.
Thank you very much, Helen, for the introduction, and good morning and good afternoon to all colleagues joining us from around the world. It truly is a pleasure to be amongst you here today and to present the charter. But before doing so, I'm curious to know whether you've heard about the charter before. So if you can go to the next slide, please, Harris. Thank you. So this question is around, have you ever heard of the charter before this webinar? So if yes, if you're familiar with it, if yes, you've heard about it, but you don't know much about it, and then if you haven't heard about it. So if you can please run the poll, Paris, thank you. We'll just wait for a couple more seconds. So the box, there's a box that just popped up in front of you there. So if you can please just choose one, it's a single choice question. Or you can also add your answer in the chat. Great, so I see a number of people in the chat have already are acquainted with the charter. So that's good. So Harris, can you please show us the results, please? Okay, so yeah, around one third of the people know about it, others don't. So by the end of this presentation, I promise that we will all learn about the charter. So then next, please, Harris, and what it includes. Next slide, please. Great. So I'd like to first start with the reason why a patient safety rights charter was developed as opposed to a patient rights charter. And I'd like to take you back to the WHO Constitution, which clearly states that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. And this right to health is not only included in the WHO Constitution, but it is also included in many other international human rights treaties. So all member states, all WHO member states have ratified at least one of those treaties that incorporate the right to health. Therefore, those member states have a legal obligation to avail health and other services necessary for the realization of the right to health. However, and it's very important to note that the care provided, those services that are provided, are actually a leading cause of harm to patients. So we're basically infringing, if we're not providing safe care to patients, we're infringing on their rights. And the burden of harm due to unsafe care is actually substantial. So 1 in every 10 patients are harmed in healthcare, and more than 3 million die because of it every year. Next, please, Harris. So patient safety is actually an integral component of the right to health, rooted in the ethos, first do no harm. Next. So since the inception of the patient safety movement in 1999, much has been done, much progress has been made in the front of the health systems, in the front of the clinical services and clinical care. However, we still see in many places that patient safety and quality of care are very much treated as a luxury and not as a prerequisite. And so we were thinking of what else can be done to support this agenda and bring it to the forefront. And so the decision was made to actually bring it to the human rights arena, so that to support and really strengthen what we're trying to do. So one of our key strategic documents is the Global Patient Safety Action Plan, which is a roadmap for the whole world to improve patient safety. And this roadmap is from 2021 to 2030. It was adopted by the World Health Assembly. So all member states have adopted the action plan. And one of the proposed actions were to develop patient safety charters or patient charters in general that emphasize patient safety and quality of care. Not only that, but World Patient Safety Day 2023 was dedicated to patient and family engagement with the slogan, Elevate the Voice of Patients. And within the framework of that campaign, the decision was made to develop the Patient Safety Rights Charter, also listening to the patient's voice. Patients really want patient safety to come to the forefront of the global attention. Next. So the charter was developed in a collaborative manner. We had an expert group that included all stakeholders, human rights experts, patient advocates. We worked with our human rights and disability colleagues within WHO and the Office of the United Nations High Commissioner for Human Rights. And the charter that you'll see now in front of you is actually based on what is existing out there, existing patient rights charters and legal instruments. So we've taken a look at what is out there from around the globe. So the first charter that was developed went then through a wide expert consultation. And what you'll see in front of you is the outcome of that. Next, please. So there are 6 objectives to the charter. The first one is to affirm patient safety as a core patient right for everyone, everywhere. To identify the key rights to be upheld when delivering safe services. To promote a culture of safety, equity, transparency, and accountability. To empower patients to actively participate in their healthcare and to assert their rights as well. To support the development of patient safety policies and procedures by member states, and to recognize patient safety as an integral component of the right to health. Next, please. So the target audience, as you can see, is quite wide, but they're the usual partners in health, but the additional ones here are the human rights experts and organizations and patient organizations and families and patients' families and the public. Next, please. So the charter is meant to be universally applicable across all healthcare settings. And it's important to note that it recognizes the importance of family and caregiver engagement as well. Next, please. So there are 3 sections to the charter. The first one links patient safety to the human rights agenda. The second outlines the 10 patient safety rights. And the third proposes actions for member states and stakeholders to adopt and implement the charter. Next, please. So this is the first section. So the patient safety, as I've mentioned, is linked to the right to health, but is not only linked to the right to health, it is also linked to the broader human rights framework. And what you see in front of you here, down in the slide, is the 30 basic human rights of the Universal Declaration of Human Rights. And so patient safety is linked to the right to dignity, the right to non-discrimination, right to life, liberty, and security. So this right is about ensuring the prevention of intentional harm and unintentional harm. And this is where patient safety comes in. It's also linked to the right to freedom from cruel, inhuman, or degrading treatment, which unfortunately happens in certain settings in healthcare, geriatric care, or mental health care. And then a right to privacy and a right to information, the right to freedom of opinion and expression as well. So I took the liberty of listing all the international human rights instruments that include the right to health as one of its main articles for your reference later on if you're interested. So next, please. So this is section 2, which includes the 10 patient safety rights. 4 of them are around clinical care. So every patient has the right to timely, effective, and appropriate care that is safe, so safe healthcare processes and practices. And this speaks about risk management, identifying risks, and reducing and avoiding those risks, and ensuring that the processes and practices that we have are safe. And then the third is around the health workforce, which need to be qualified and competent. Medical products and their safe and rational use is extremely important, and it's also one of the rights. So there is a right dedicated to safe and secure healthcare facilities, so the environment as well. One right dedicated to how we deal with patients, dignity, respect, non-discrimination, privacy, and confidentiality. 2 of the rights relate to information sharing, so empowering patients with information, so access to medical records, education, and supported decision making. The 9th is around being heard, so elevating the voice of patients and ensuring fair resolution when harm does occur or where there are incidents happening. And then the 10th is around patient and family engagement, not only in their care, but in the wider health system as well. Next, please. So we come to our second question. So we'd really like to know, in your opinion, which patient safety right, now that you've been introduced to them, might be the most challenging to uphold in your country? So you are free to choose more than one option. So those are the list of the rights. Harris, can you please launch the poll, please? So again, you can choose more than one option. So I'm going to take a look at the chat here. If it's easier to write in the chat, please feel free to do so as well. So we'll wait for a bit. Okay. So please, Harris, can you please show us the results? One, 3, and 9. Right. So I see that the main concerns are around timely, effective, and appropriate care, and information, education, and supported decision making. The third is around patient and family engagement. So interesting results that the health work, the rest are more or less the same, but then the major concern is timely, effective, and appropriate care. Okay, thank you very much for sharing. So this really brings us to then how do we ensure that the Patient Safety Rights Charter can be implemented in a manner that would support us in implementing those rights where we feel there are weaknesses or countries would have challenges to uphold. So next, please, Harris. Yes. So these are the 9 actions that WHO proposes for member states and stakeholders to adopt and implement the charter while adapting it to the national and local context as appropriate. So the first thing that is proposed is to conduct a stakeholder analysis and to engage, so identify which stakeholders we need to engage and do so in an active manner and from the start, and not to forget those communities that are usually forgotten. So vulnerable populations need to be in there as well. The second is around the legislative framework and regulatory mechanisms, and really there's a need to also understand what is there in terms of legislation and regulation before incorporating the principles of the Charter into these frameworks. We need to understand what's out there as well when it comes to the professional guidelines and incorporate the principles accordingly. The fourth is around accountability, remedial and incentive mechanisms, and the need to establish those mechanisms. There, we have to be accountable to the way this charter is implemented, but it's not only always about punishing, or it's also about identifying good practices and incentivizing them. So it's important also to have a structured or wide communication campaign and to work a lot on advocacy to engage communities and engage frontline health workers and to develop targeted messaging for each of these stakeholders. Capacity building is key, not only for health workers on the competencies of the patient of the charter, but also of the patient advocates to become leaders themselves and to play an active role in implementing the charter. Monitoring and evaluation is extremely important, so we need to have metrics to measure how the charter is implemented and its impact on the patient safety, on patient satisfaction, amongst others, and to use that information for improvement. Research is extremely important for us to modify those rights according to the outcomes of the research. And then finally, learning from each other. So international collaboration and sharing best practices is extremely important. Next, please. So this brings me to my final slide. Next, please, Haris. There was another slide, Haris, if you can please share the screen again.
Can you see my
Yes.
screen?
Yes, so there's another slide after this one. Yes, I needed to show this one. So I really wanted to end with the words of Dr. Martin Luther King, who and Dr. Tedros, the DG of WHO. So Dr. King said that of all forms of inequality, injustice in health is the most shocking and inhuman because it often results in physical death. And unsafe care also often results in physical death. That is why Dr. Tedros always says that if it's not safe, it's not care. Thank you very much.
Thank you so much, Ida. Let us move on. Next slide, please, Harris. Elevate the voice of patients. Next slide, please. So our next speaker is Jolanta Balinska. Jolanta is the Director of Development and Social Communication at the City Medical Center in Lodz, Poland, and the EU Coordinator for the National Health Fund in Lodz. She's also a former journalist who's published extensively on patients' rights and a founding director of the World Patients Alliance. So with no more ado, I will let Jolanta begin her presentation. Next slide, please.
Good morning, good afternoon. I am very, very happy for the invitation that today we have a chance to see this WHO project, but I also want to show what we do in European Union, and because Poland belongs to European Union, so what we do historically, because the history of patient rights is not very long, even in my part of the world. Next slide, please. As you know, in European Union, the first initiative was launched in 1984. European Parliament noticed that people, patients should have their rights. And the first time in 2002, in European Union Charter of Fundamental Rights, we saw the 13 core patients' rights. They also mentioned that we need to celebrate, promote this European Patients' Rights Day annually, and every year, 18 April, it is a celebration for patient rights. Of course, in these rights, you can see in the next slides, we have no time to go through all rights, but I think they are very, very important for support health, to have the information, the dignity, etc. But what I wanted to mention, in 2003, last year, 36 organizations started to fight about the advocacy for data privacy. And all organizations, even patient organization, wants to protect patient rights in European health data space. What it means? That opt-in consent is necessary for any health data use by stakeholders, and it should be confidentiality. Next, please. Next slide. The next information is about the patient rights in Poland. You know, I need to tell you that when Poland was in the communistic time before 1990, the Polish People Republic, it was a difficult era for citizens and for patients. First of all, rights to information about our health condition had the family, not the patient. Patient was never informed if without any family permission. So it was strange, but it was. Patient had only good news. This bad news where family was informed about this. It was no confidentiality, so medical documentation was accessible to everyone. It was no any data protection. It has, of course, changed after 1990 in democratic Poland. So patients' rights gain significance, reflecting democratic values, which are a standard in the European Union. The most important act on patient rights was from 2008, so not very long history, and there are 12 fundamental rights addressing confidentiality, consent, dignity, and access to medical care. It is also very similar with national and European Union regulation that it should be work together, patient safety and healthcare quality. Next slide. I will tell you that, for example, at the beginning, patients received these rights in 2008, but they didn't know how to use these rights. I give you one example. In 2005 or 6, WHO launched the challenge about hand hygiene. Everybody was informed that people, if they have any treatment, the doctor should or the nurse should wash hands before touching. But they were only maybe 1% of patients who asked the doctor, please wash hands before touching me or before starting any treatment. Or same to nurse. So people knew that these rights exist, but they didn't know how to ask about proper information, how to report adverse effects of medicine. They didn't know that confidentiality is a special right. You know, we had an actress and she has cancer. So after her death, the doctor today, Ashok, told it. Even after death, nobody should know what was the reason, and she had many pain or not, which medicine she took, and all about this actress. Her doctor referred in media, in social media. If it happens in not democratic Poland, nothing happens to the doctor. But nowadays, these secrets which he revealed put him to ethical commission. So the patients now know there is nobody who can tell about you even after your death or when you are alive about your treatment. So these rights are very important now. I want to turn your attention about two rights which are totally different than in European Union. It is right to pastoral care and right to secure valuables. You know, patients, when they go to the hospital, many times they ask for help from the priest. Nowadays, in Poland has changed. We have Muslim, we have from many people from Ukraine, and now we have different religion, and all this information are in every hospital, in every ward. how to contact the priest, the pope, imam. So this is our exceptional thing. And this secure valuables, it is also exceptional because sometimes people, if they go to the hospital in Poland, they take with them a lot of money, everything, because they think maybe it could help. Although we are all insured in a national health fund, so we don't need any extra money. Next slide. I know I have not much time. Next slide. If we have in European Union, there are 14 rights, and these rights are to proactive health protection, access to health, information, consent form, free choice, privacy and confidentiality, respect for patient time. We have also high quality care. We want to safety care, access to innovative medical advancement. We don't want that patients suffer pain, and the medical care should be also tailored to individual needs, and right to compensation. They are special mechanisms for addressing grievances. Next slide. How we understand this right according to patient rights, it was mentioned by Dr. Aida and by Dr. Ashok. I will not repeat what it means access to care, what means access to information, free choice, and all these rights. Next slide. I will concentrate. Yes, also this next slide. I will concentrate on some patient rights in action. So Supreme Audit Office published 2 months ago some cases of infringement patients' rights in Poland. It's more interesting for you because you have also your rights in your country, and in my country 30% of hospitals didn't provide decent conditions of stay during treatment. It is what WHO called a sustainable stay in the hospital. So in some of our hospitals, in 30%, they are destroyed beds, or the devices are very old, or they are any other conditions which doesn't allow to patients to have a good conditions in the hospital. 65% of patients, so this is a lot, didn't receive information about waiting list to the doctor, about confirmation, about rights to access to health. In patient rooms, they were not screened, so intimacy was not provided. And one very bad example of destroying patient rights. In some hospital, in gynecology department, room stillbirth was very near to live birth. So both patients heard each other. They were in touch. It was a horrible experience. In 35 of patients didn't receive information about higher risk of surgery. The form which they filled was not adjusted to this procedure. 30% of hospitals didn't provide a monitoring of pain assessment. So this is also, they are rights which exist on paper, and they not exist in praxis. In medical documentation, they were not mentioned bed sore. It was in 42% of hospital. They were also incident of wrong documentation of adverse events. So Ombudsman of Patient Rights registered more than 6,000 cases for individual patients. Okay, next slide. where is the role of NGO and advocacy groups in supporting patients' rights? I think it is a platform to exchange experience, to create more aware patients about needs and engagement. I hope now we can promote everywhere as patient organization this WHO Patient Safety Charter. Next slide. How to improve patients' safety rights. So we need prioritize safety. Healthcare providers can improve the overall quality. We can trust in healthcare systems, so patients should feel safe and protected, and we can preventing medical errors and reduce healthcare costs. And we can also contribute to public health by preventing the spread of infection and disease within healthcare settings. Next slide. Thank you for attention, and I return the voice to Helen. Thank you.
Thank you, Yolanta. That was very informative. And our final speaker, last but far from least, is Cecilia Nantume, nurse midwife and public health professional in Uganda. Cecilia holds many advanced degrees, including from Karolinska Institute. She's currently working with patient organizations in Uganda to advocate for equitable access to high quality care and patient safety. So Cecilia is going to talk to us about the Ugandan patient rights charters and how they have affected patient rights there. Cecilia.
Thank you very much, Helen, and the previous speakers for such informative insights that you have given us. I'll be talking about the Patients Charter in Uganda, but I'm going to focus my presentation on seeing how it aligns with protecting the societies from preventable harm. Thank you. Next slide. So the Patients Charter in Uganda enshrines quite a number of rights, and many of them have already been listed by the previous speakers. So I would like to do a short comparison between the Ugandan Patient Charter and the WHO Patient Safety Charter. Like I'd already mentioned that the one for WHO is actually a patient safety charter, not a rights charter, while ours, it's a rights charter. So it just talks about the entitlements that patients have. And when you look at it critically, it partially has some broad themes around safety, but they are broadly enshrined in the different entitlements that are listed in the charter. And it mainly focuses on access, equity, and general quality of care rather than the systemic prevention and management of harm like the WHO Charter does. But to point out some of the key elements in the charter that allude to safety is, of course, the right to safety and security, the right to proper medical care, informed consent, confidentiality and privacy, continuity of care, a right to redress, and a right for patients to access their healthcare information. Next slide, please. Next slide, please. Next slide, please.
The slide is already there.
Oh, sorry. Sorry, I was waiting for it to go. And some of the key limitations of our charter for it to function as a safety charter is, of course, some of the things that I've already mentioned, but it generally lacks a comprehensive safety framework it does not really address systemic risk in healthcare provision. And safety is integrated into broader rights like the medical care and security. And it has no emphasis on how to prevent harm. For example, if you want to go in depth to look at things like patient identification, use of evidence-based pathways and transitions in care. But on that point, I would like to mention that we actually have comprehensive healthcare standards that allude to some of these things that are deficient in the Patient Rights Charter. And when we talk about patient engagement and community engagement in improvement of safety, for it, one of the rights that it points out is that patients have a right to be represented either as individuals or through institutions and be a part of healthcare policy development. But it does not really talk about engagement. It's just that, yeah, let's have the patients in and let them be represented, but there is no deliberate effort to really go out to engage them to get their views and in the policy development process. Next slide, please. Yeah, and some of the challenges that we have faced in enforcement of this charter is that much as it has very good spelled out rights, the fact that the Ugandan Constitution does not explicitly guarantee the right to health, it makes it so hard to enforce violations of the rights of patients in courts of law. So it's more of a policy guideline, but it's not very easy to enforce it to enforce it for that reason. And second, many Ugandans, and when I talk about Ugandans, I talk about clients and health providers, are not aware or they do not fully understand their rights. And when we wrote one of the articles that we put in, people would come to my WhatsApp inbox and they say, I didn't know that I actually had rights. And also coming from my health professional perspective, by the time I was in school, no one told me about the Patients' Rights Charter. I actually found it in practice and it's hung around the walls, but no one really made a deliberate effort to go ahead and explain to me how to apply those rights in practice as a practicing professional. So you see where that gap comes from. And then when it comes to the and there through NGOs and civil society groups that want to work towards enforcing the patient's rights, but of course they also are limited with funding, then they are limited with the capacity to form strong coalitions to be able to push through the agenda of patients' rights in Uganda. And then the other one that is really the main constraining factor to enforcement of and compliance to patients' rights is the limited funding of our healthcare system. Much as our healthcare providers may know what to do and they know these rights, but because of the limited funding of the healthcare system, we find ourselves so constrained with resources that even when you know the right thing to do, for example, I will talk about the right to appropriate and timely care. Yes, a patient comes to you and you know what to do, but you realize to offer that emergency service, you need the appropriate diagnostics, you need the right drugs, you need the right consumables, and all of those may not be available at the moment. So you end up violating that right of a patient to actually get appropriate, adequate, and timely care because of the constraints that you, a healthcare professional, is going through. But then still, regarding to the limited funding of the healthcare system, it also limits the capacity of the Ministry of Health and other relevant bodies to perform their oversight role in ensuring that actually patients' rights are enforced and adhered to. Then, of course, there is the lack of the political will. Yes, we are very quite persistent in trying to say how committed we are to improving the right to health of everyone. But of course, the political will to have this enforced becomes a challenge, as you find so many politicians may not want to join coalitions that want to advance the right to safety. And then the other problem is that we don't also have reliable data and evidence that we can have that we can point to have to have our case built in case we want to advocate for enforcement of patients' rights. And then, of course, generally there is a resistance to systemic reforms in health. Next slide, please. So my next slide is talking about what opportunities do we have to improve as a country. And I want to point out that some of the issues I've mentioned and the challenges are actually applied to most of the low-income countries from the answers to the poll that were put there by Ada. I saw someone in the chat saying almost everything is a problem to realize in most of these countries. So, but for Uganda, one of the opportunities that we have is, first of all, to have explicit inclusion of the right to health in our constitution. Continue having awareness campaigns to educate citizens on their rights, increase the funding to the healthcare system. We have never achieved the Abuja Declaration for funding for our healthcare system. We need to build capacity of healthcare workers. We need to strengthen monitoring and redress systems at all levels. And we need to privilege political advocacy to make sure that we engage those few willing politicians to be able to push this agenda forward. Next slide, please. And I think that is my last, and I see we are also already out of time. Thank you.
Thank you to all of our speakers. I am so sorry that we don't have time for the question and answer. We've gotten some very good questions in the chat. You can contact the speakers via the World Patients Alliance. Just write to info@Patients Alliance. And the recording of the webinar will be on the website along with links to the documents that have been mentioned. And we will ask the presenters if we can also have a PDF of their slides. Thank you all very much. Andrew, did you have something that you wanted to add before we closed?
I simply wanted to say what you just said. Thank you very much to all of our speakers, including you, and especially you, Helen, and all the great work that you're doing for the World Patients Alliance. Just a big thank you for all of our members for attending. We had amazing attendance today. I know we're over, so I'm just going to close out and say thank you, everybody. We'll see you at the next webinar.
Okay, thank you. And I see that Dr. Phillip has joined us. I'm so sorry we did not have a chance for a live discussion with him and our other speakers. Thank you all for coming, and we will be in touch. We will see you soon. Thank you.
Thank you all.
Thank you.